You have a 44-year-old male of Mumbai presented at one of the major municipal hospitals in February 2014 with complaints of chronic cough for 11 months, progressively increasing shortness of breath for 10 months. Cough was not associated with expectoration or hemoptysis, and there was no aggravating or relieving factor either for the cough or the breathlessness. No associated symptoms of chest pain, wheezing, cold, fever, weight loss. Sleep appetite, bowel bladder habits were normal. Prior to presentation, the patient had visited two physicians for his complaints, received symptomatic treatment after investigations, but no definitive diagnosis was done. All right, why I'm discussing the case history, because this is important later on. Now, this may not be TB to present with, okay, and what is the diagnosis I'll come to shortly. Past history did not reveal any major illness or disease. The contact history was insignificant. The patient was a non-smoker and did not consume alcohol or have any other addiction. On examination, his vital signs were stable. Digital clubbing was present, which only indicates that there is something chronic going on in the body. Chest examination was unremarkable except for a few crackles heard bilaterally, which doesn't give us, any major information at all. The chest X-ray revealed bilateral micronodular shadows, predominantly in the right lung field, but also in the left lung field. And hemogram was normal except for a borderline elevated ESR. Sputum smear for acid-fast bacilli was negative, and serology was non-reactive for retroviral disease and hepatitis. Now, based on the above evaluation on this X-ray, the patient was diagnosed as a new case of smear-negative pulmonary tuberculosis and prescribed a course of anti-TB therapy of INH, rifampicin, pyrazinamide, and ethambutol. But there is something on this X-ray which gives us an important diagnostic clue, which was missed that time, and I'll come to that again shortly. So what happens? This is Feb 2014. However, 2 months into this treatment regimen, the patient's symptoms had not been relieved, and now new symptoms have appeared. He noticed reduction in his weight and his appetite and the appearance of fever. So after 3 months in May 2014, he comes for a second opinion to us. We also examined him. We took an occupational history. We found that he's been working in a chucky, that is a flour mill, for more than 3 decades. His father also used to work in the same chucky, and he would often assist his father since a very young age. On examination, again, there's digital clubbing, which will tell you that there is some chronic disease going on in the body. You have the presence of bronchial breath sounds for the right intraclavicular, inframammary, axillary, and upper interscapular areas, which tells you that there is some pathology in the lung parenchyma or airways, and scattered crackles heard bilaterally. Okay. Again, the CBC does not show anything except for a mildly elevated ESR. Routine biochemistries like creatinine, liver function, blood sugars, thyroid stimulating hormones, total IG, which is done in such cases with an X-ray like this, all were normal. ECG and 2D echo again normal. Sputum smear for acid-fast bacilli, two samples. CBNAT, which is your gene expert, and LP of sputum again were negative. Spirometry revealed mild obstruction with bronchodilator reversibility, which is expected in a patient like this. So we evaluated him further. We did a chest radiography, which revealed small micronodular shadows in the right lung extensively and left lower zone with eggshell calcification of the left hilar node. You can see it here, and this is a magnified shot of the same. Now, eggshell calcification is suggestive of silicosis, though it can occur in other diseases also. So, why silicosis? I'll come to that again. But what I'm trying to show you is that there is something apart from tuberculosis in this patient. And from X-ray, you go to a high-resolution CT chest, which showed patchy consolidation and branching or tree-in-bud opacities in the posterior segment of the right upper and apical segment of the right lower lobes, adjoining fibrosis, traction bronchiectasis, and fibronodular opacities extensively in the right lung field and in the apical segment of the left lower lobe, and enlarging calcified left hilar, prevascular, pretracheal, and paratracheal nodes. So what have we got here ultimately? You see, we still don't have a definitive diagnosis of TB, okay, because those tree-in-bud opacities can also occur in some viral infections, bronchiolitis, etc. So further evaluation by fiber optic bronchoscopy to confirm the diagnosis was advised, which the patient consented to. It was performed under local anesthesia and conscious sedation. The bronchoalveolar lavage revealed acid-fast bacilli. Gram stain and bacterial cultures were negative. The bronchoalveolar lavage gene expert was positive, showing Mycobacterium tuberculosis with medium load and the presence of HIF resistance. Bowel samples were also sent for mycobacterial culture and dust receptor testing to a nationally accredited reference laboratory. So now at least you have a definitive diagnosis. And what is that? you have pulmonary silicotuberculosis, okay, with rifampicin resistance. Now, why silicotuberculosis? Because the presence of the source of silica particles in flour mill workers in India is the Agra stone, a red stone with an exceptionally high silica content, which is used to chisel the large grinder in the mill, during which a significant amount of silica dust is generated. So the patient is informed and counseled about the diagnosis. Treatment is initiated both for the tuberculosis with rip resistance. Here you have an appropriate anti-TB drug regimen adjusted for body weight with regular follow-up. But you also have to treat the symptoms. It's not that you treat the TB and the silicosis will go by itself. You have to treat the symptoms there. So you have to relieve his bronchospasm by giving long-acting bronchodilators and corticosteroid via dry powder inhale. Is this all? No, it's not all. Mycobacterial culture DST reports at 6 weeks revealed an extensively drug resistance pattern with the isolate showing resistance to INH, rifampicin, ethambutol, pyrazinamide, streptomycin, kanamycin, amikacin, and ofloxacin, and susceptibility to other anti-TB drugs like moxifloxacin, clofazimine, ethionamide, pyraminosalicylate, cyclosporine, clarithromycin, and capreomycin. So 6 weeks later, the treatment regimen has to be changed to a more individualized and DST guided one of moxifloxacin, ethionamide, cyclosporine, pyraminosalicylate, clarithromycin, clofazimine, and capreomycin. In short, all the drugs he's susceptible to. Now, why am I showing this? I'll come to that again subsequently later in my talk. Now, since the patient was unable to change his occupation for obvious reasons, he was advised to use personal protective measures like wearing a mask over the nose and mouth at all times while working in the flour mill. So finally, after a month of starting this different regimen, the patient reported relief of his dyspnea and cough, followed by resolution of the fever, improvement in his appetite, and marginal gain in weight. He was monitored with hemograms, creatinine, liver function, and TSH every month, and chest radiographs every 3 months for 6 months. At the end of 6 months, a chest HRCT was repeated and revealed significant clearance of the consolidation and some persistence of some residual lesion. Lung function was stable, and sputum mycobacterial culture was negative at 6 months. The inhaler therapy was continued. The anti-tubercular drug regimen also was continued with the exception of the injectable, okay, for another 18 months. Again, the patient was monitored every 3 months by chest radiograph, hemogram, creatinine, TSH, and liver function, which were normal throughout. Spirometry was repeated after a year, and lung function parameters were stable. So ultimately, all's well that ends well. At 24 months or 2 years of treatment, sputum mycobacterial culture is negative. HRCT of the chest reveals clearance of the consolidation and persistence of some residual lesions. Anti-TB drug therapy is discontinued at this stage. Inhalation therapy is continued. The patient is advised to continue protective measures like wearing a mask and get himself vaccinated with seasonal influenza and polyvalent pneumococcal vaccines. Since the last 4 years, the patient is regular with his inhaler therapy, follows up every 6 months, and is stable, symptom-free, and without comorbidities. So what I'm trying to say is that if we had some test earlier, we had to go to 3 sputum samples coming negative, then 2 gene experts coming negative before the third one came positive also. So if we had a test, which I'm going to talk about very briefly, this could have changed the management of this patient. He could have been initiated on this regimen much earlier in the course of his disease. So there are some advances in Gene Expert. You have the Expert Ultra, which has a larger chamber for DNA amplification and thereby enhanced sensitivity, less likelihood of false positives, and you can use it with the existing Gene Expert equipment. All you have to do is upgrade the software. Then you have TrueNut, which is an indigenous test developed by an Indian company in Goa, which requires far less, just half an ml of sputum as compared to a conventional 1 or 2 ml with Gene Expert. Results come again within 1 or 2 hours. It's battery operated and portable with good sensitivity and specificity, therefore makes it suitable for field settings. You have some advances in culture also. You have the microscopically observed drug susceptibility assay or MODS, the nitrate reduction assay or the NRA, and the colorimetric redox indicator. Some of these tests like the MOD and NRA are direct, and all three of them can also be done indirectly on isolates other than sputum. All right. So now coming to whole genome sequencing, very briefly I'll go through this. Whole genome sequencing, also known as full genome sequencing, complete genome sequencing, or entire genome sequencing, is the process of determining the entirety on nearly the entirety of the DNA sequence of the genome of an organism at a single point in time. How can it be useful in TB? Friends, resistance in tuberculosis is mainly conferred by nucleotide variations. Whole genome sequencing uses high-resolution gene sequencing technology to interrogate the entire mycobacterial genome and identify drug resistance across all the anti-TB drugs used. In addition, it can also give you a diagnosis of mixed infection, co-infection, or heteroresistance. It's now been increasingly recognized and adopted for TRTB diagnosis and treatment in many countries of the world. All right, you have the sample collection, culture enrichment, DNA extraction, pre-sequencing preparation, sequencing, data analysis, and finally generation of the report. So it's quite complicated. So you look here, you have 18 drugs for which TB whole genome sequencing can be done. These are the drugs and the genes, you can see them. I'll not go into details, but what is important, unlike your gene expert and LPA, you can do EST to so many other drugs which are useful particularly for treating DRTB. How does it perform? Let's take a look. The sensitivity and specificity to your first line anti-TB drugs is excellent, both above 90%. Even to your second line anti-TB drugs, you have very good sensitivity and specificity across the board. And how does it perform versus culture? There is good concordance between culture DST and whole genome sequencing to the tune of 93% as compared to LPA, which is 63%, or CBNAT, which is just 49%. So friends, whole genome sequencing resolves an unmet need. It has great potential for rapidly diagnosing any type of drug-resistant TB in diverse clinical reference laboratory settings worldwide, and it overcomes many of the limitations associated with conventional phenotypic tests, that is your culture, and also the limitations of other less comprehensive molecular methods, that is your gene expert and LPA. So this was the old diagnostic algorithm for TB. You had clinical symptoms, then you took an X-ray, then you did your sputum smear, then you did a NAT, then based on whether it was positive or negative, again you would have to do a culture. Very long process in short. This was what we used to do 7 to 8 years ago. And then for pulmonary TB, the standards for TB care in India, a vision document released in 2014, said you have to do microbiological confirmation on sputum, chest X-ray as a screening tool, and then finally go to your CB-NAT. For extra pulmonary samples also, microscopy, culture DST, CBNAT, or molecular tests or other things. So now whole genome sequencing for TB is recognized and recommended. The WHO also mentions it, and there is, you see, though it has not been fully taken up, it finds mention in the recent guidelines released this year for programmatic management of DRTB in our country as well. The advantages of whole genome sequencing is that it detects genomic sequence variants, phenotypes, and guide treatment decisions in DRTB. It overcomes the challenges associated with conventional phenotypic tests, that is your culture, because discrepancy in culture for certain RPOB, for rifampicin and gyre, for fluoroquinolones in media, as well as the complications of diagnosing pyrazinamide drug resistance. Pyrazinamide is a drug which works only in acidic medium, and all our culture media, whether solid or liquid, are mainly alkaline. So there is discrepancy between drug susceptibility in vitro and in vivo. It can be considered a more robust reference standard for drug resistance profiles. It also overcomes the limitations of other less comprehensive molecular tests such as Gene Expert or LPA by providing rapid and detailed sequence information. It can detect heteroresistance or a mix of multiple genetic populations in a clinical sample. It assesses lab cross-contamination for diagnosis of other infectious diseases. Finally, it's important in the public health domain also because it can identify strain lineage and resistance mechanisms for TB surveillance and recognize genetically related strains for the resolution of transmission chains to direct TB control and elimination efforts. The disadvantages are it's expensive, it's technically complex, it requires a lot of hassle for integration into existing lab workflows, specific training and skill requirements, and expert guidance also regarding clinical interpretation of the sequencing data. There can still be discordance between the detected genes and the resistance phenotype for some drugs, particularly fluoroquinolones. And the breakpoint artifacts, that is inappropriately high CC values, might lead to misclassification of phenotypes. So all said and done, friends, no lab test is 100% foolproof or 100% foolproof, and phenotypic tests, that is your culture and genotypic tests, such as your gene expert and LP, are no exception. Keep in mind the molecular detection of resistance will depend ultimately on the persistent presence of the resistance conferring mutation, and alternate mechanisms of resistance may develop or mutations may appear which the test was not designed to detect. Hence, you require phenotypic tests to identify resistance as well. What will you do even if you have a definitive diagnosis? Because treatment is not like instant coffee. Treatment will go for 6 months to 9 months if it is a drug susceptible TB, and for at least 2 years if it is a drug resistant TB case. Sometimes the lesions may persist or enlarge. Sometimes TB may develop at another site when the patient is on anti-TB treatment. So you think of a lot of things. You have to evaluate thoroughly, imaging, sampling, etc. Think of immune reconstitution or paradoxical reaction. Don't just think that this is a drug-resistant case. And you have sometimes faced the dilemma of hetero-resistance, that is different resistant populations at samples isolated from different sites in the same patient. So for such cases, culture is always superior. In theory, there is no difference between theory and practice, but in practice there is. Molecular methods may be rapid, but then speed and shortcuts don't always win. You have the story of the hare and the tortoise here, and we all know who won the race. So my take-home messages to wind up are that whole genome sequencing is proving to be the go-to test for DRTB diagnosis with the potential to get patients on the right treatment path early. For every case of TB, you must thoroughly evaluate, investigate, strive to establish a definitive diagnosis, and then after you've done that, establish whether it is drug susceptible or drug resistant TB. If drug resistant, then whether MDR, XDR, or any other type. All said and done, even after you have a definitive diagnosis, even after you've started the best treatment, the patient still has to follow up with you and you will be assessing him or from time to time. So no amount of evidence can replace your clinical assessment and judgment of the case. The final word is by these two gentlemen here, the pioneers in TB, to Robert Koch and Louis Pasteur, who say, it's about time we had a good rapid test. These are a few references, and with this I conclude. I'm extremely grateful to all of you here for giving me a very patient hearing. Thank you.